Welcome to Oncology Data Advisor. I'm Kira Smith. Today I'm here with Dr. Thomas Abrams, the new Editor-in-Chief of Oncology Data Advisor.
My name is Tom Abrams. I'm a GI medical oncologist at Dana-Farber. I've been there since 2006, and I see patients and I engage in clinical research. It's been a wonderful career for me there, and I'm really excited to be editor-in-chief of Oncology Data Advisors. This is a really fantastic online journal trying to spread information about cutting-edge treatments in oncology, and we have a wonderful editorial board filled with experts in the field, and I think we can really continue to grow the journal and make it something that I think will be a resource for anyone interested in oncology.
Well, thank you so much, Dr. Abrams. Very excited to work with you.
Likewise.
So what led you to become a researcher in the field of gastrointestinal cancer?
Well, you know, I came to medical school at Jefferson really not knowing that a doctor could have a thriving clinical practice, but also engage in research. I knew of doctors like my pediatrician who saw patients, and that's what he did. And that's sort of what I thought of when I went to medical school. But in medical school, I had role models who really did split their time between clinical practice and research. And it turned out that they were almost always the best teachers. And when I decided during my internship that I wanted to pursue a career in oncology, I did a clinical research project with Larry Baker, who is a sarcoma expert at the University of Michigan, and stayed at Michigan for fellowship and worked with Dean Brenner on a project in Barrett's esophagus. And these experiences really were so fantastic and really shaped the basis of my decision to remain in academics. I knew right away that I didn't have the temperament for bench-based research or being a full-time researcher, and that wasn't ever my plan. My first love is clinical medicine, but I think it really does give you the chance to branch out intellectually and have a varied and more sort of exciting career to be able to do multiple things and engage not only in patient care, but in clinical research as well. Earlier in my career, I had several grants to do work in patterns of care, basically trying to determine how chemotherapy was used in certain situations. And I was fortunate enough to be mentored by Charlie Fuchs, who is one of the great clinical researchers in GI oncology. And we learned, interestingly, that in colon cancer there was relatively low use of some active agents, and in gastric cancer it was kind of like the Wild West. So many different regimens were being used, and I think that really contributed to the understanding that there's wide variation in how chemotherapy is being used. But nowadays, I'm spending more time leading a research group in primary liver cancers. We're enrolling patients at high risk for developing liver cancer into a program of active surveillance, hopefully to improve outcomes, identify novel biomarkers, and allow for early identification of cancer. Ultimately, we would like to expand our efforts to include patients at different stages of illness, but we're still a pretty young group, and we have a lot of growth in store, and it's very exciting. The future is bright.
So what are some of the recent advances in the field that have changed the management of gastrointestinal cancers?
Well, progress is somewhat slow, but steady in GI malignancies. And we continue to slowly unravel the secrets of the cancer genome, particularly as it pertains to mechanisms of carcinogenesis. We've been able to identify new treatments and new approaches through analysis of these genetic processes. In particular, advances with respect to immunotherapy in treatment of upper GI malignancies, PARP inhibitors for BRCA mutated pancreas cancers, and immunotherapies in a number of different other GI cancers, including liver cancer, have have really changed the outlook for many patients with advanced and even earlier stage disease. But I don't think we are anywhere near where we will be in the next 10 to 15 years. I think the field will continue to evolve as genomic pathways are elucidated, as the contribution of the epigenome and the microbiome is elucidated, and the interactions are understood, and also as tests for early identification for cancer continue to be refined. So we're a long way from where we will be, but we're right on the cusp. It's quite obvious that we're we're making important strides in basic science that are going to translate into the clinical realm, but it's hard to predict. But I think really the thing that's hopefully going to really change the field for the better is early detection. Almost every day in the medical literature, you can find articles describing a new blood test or a saliva-based test that can detect cancer in its primordial stages, and ostensibly when it can be cured. I treat cancers that in the advanced stages, and that's most of my patients, they are life-limiting. They are ultimately diseases in which the patient's going to die. And we can extend survival, we can preserve quality of life, but we can't cure them. And that's not only terrible to hear for the patients, but it's disheartening for we doctors, because we're not curing enough people. But if we have these tests and we can find patients who are have preclinical cancers, it would be amazing to me that if the cure rates weren't much higher. So I think that's really going to be the thing that, if it delivers on its promise, and that's that remains to be seen, then I think the field will change enormously.
Well, thank you so much for sharing all this valuable information with us.
Oh, it's my pleasure. And again, I cannot wait to be part of this, and I'm just so honored. So thank you, Kira, and we'll talk soon. Bye-bye.